Call the meeting to order. Good evening and Happy New Year. Let's rise for the Pledge of Allegiance. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Thank you. Cheryl, would you please take the roll?
Director Wallace?
Present.
Director Nicholson?
Present.
Director Yee? Present. Director Stewart?
Present.
Director Eapen?
Thank you. Welcome to the January 10th, 2024 regular meeting of the Washington Township Healthcare District Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and is also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular session of the board meeting. It will be posted on our website for future viewing. Let's see. Are there any oral communications?
No.
Members, well, of course, let me...
There's no oral or written.
Yeah, members of the public are invited to speak during oral communications when prompted. Please state your name for the record, then proceed with your statement not to exceed 3 minutes on issues or concerns not on the agenda and within the subject matter of jurisdiction of the board. Are there any members of the public who would like to speak at this meeting? None? We'll move on. Are there any written communications? Cheryl, are there any written?
No, there's no written communications.
Thank you. So we're going to move on to the consent calendar. And I have a motion for the approval of the consent. Oh, well, another speech. The old days, we just go right into this.
Yeah.
We will now move to our consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion, unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting until under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove an agenda item from the consent calendar? May I have a motion to approve consent calendar items A and B?
I move that the Board of Directors approve the consent calendar items.
Thank you. Second. Thank you. Cheryl, please.
Yes. Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Eapen?
Okay, thank you. We'll now move to the presentation.
Yes. It's my pleasure this evening to introduce Dr. Seema Sehgal. She's a psychiatrist with Washington Township Medical Foundation. She is board certified with the American Board of Psychiatry and Neurology. She earned her medical degree at the Armed Forces Medical College in Pune, India, before coming to the United States for her internship and psychiatric residency at California Pacific Medical Center in San Francisco. Dr. Sehgal served Fremont community for 16 years as a staff psychiatrist for the Alameda County Behavioral Services Department and the Alameda County Crisis Response Program. This experience in treating patients from widely diverse cultural and ethnic backgrounds provides Dr. Sehgal with a unique experience and perspective for the influence of culture on the varied presentations of psychiatric illnesses in our community. So it's my pleasure to welcome Dr. Sehgal, and she is going to be speaking this evening on anxiety and depression.
Thank you, Kimberly. Can everyone hear me and see me okay?
Yep.
Yes.
Okay. All right. I am so excited to be here because this is a topic that is gaining so much traction, and depression and anxiety are two illnesses that are becoming ubiquitous and so prevalent in our day-to-day lives. Next slide. Every talk on mental illness that I give, I always like to begin with a definition of what is mental health. And as you can see in the definition that follows, mental health is certainly not just the absence of mental illness. In fact, there is no universally accepted definition of mental health, but we generally think about it as including our emotional health, our psychological health, as well as our social well-being. It affects how we think, feel, act, how we handle stress, and how we relate to other people. If you just pause for a minute, you will notice that happiness really figures nowhere in the definition of mental health. In fact, the opposite of mental illness is not happiness, but vitality. It is the way we connect to all aspects of our life, be it our work, our relationships, home, our social functioning. And so I like to think of it as a balance between what is happening to me and what I perceive or what I interpret as happening to me. And that is why when we put two people through a similar stress, we realize that they experience that event completely differently and have a completely unique emotional response to it. Next. People will often ask, what are some of the factors that influence our mental health? Why do I get depressed? Or why does a loved one or a friend experience mental distress? And I like to, really simplify things and think about the different factors as fitting into three buckets. The first bucket, which is biology, is all the things that I'm born with. This is my own wiring, my coping mechanisms, my personality style, which is usually wired into us at birth, my genetics, family history, any drugs or alcohol exposure in utero while I was, in the womb. All of these are things that I was born with. Very little influence I have over that. The second bucket is the social determinants of my mental health. And those include my experiences through life when I'm a child, an infant, young adult, my family environment, all other determinants like poverty, education, exposure to parental discord, drugs or alcohol in the parent, separation, divorce, grief. Again, these are things I'm born into. So there's things I'm born with, there's things I'm born into, and these two I have limited control over. The third bucket, this is what I like to call the golden bucket. And this is what I bring to my life, to my situation and circumstance. And this is where I can really work hard at fighting and working hard to having the mental health that services me through life. And this includes my belief system, my coping strategies, my ability to manage stress, learning coping skills, as well as my own attitudes towards mental illness or mental health. And all of these are, the areas that I like to work with patients when they come in to see me. Next. Now, this is, not a surprise to any of us that the incidence of depression and anxiety has really skyrocketed. It leaves nobody untouched. We either have experienced it ourselves within our families, we've seen people suffer, and certainly we've known friends who have struggled with this. And if you combine the two, it's almost 500 million people worldwide who are touched by these illnesses. And in the United States, we used to think anxiety was 1 in 4 or 1 in 5 people. So roughly about 20 to 25% of people who would suffer from some form of anxiety. During the pandemic, however, these numbers really increased up to including 1 in 2 or 1 in 3 people who had some variation of a stress response because of the stress of what they were going through or witnessing other people go through. And there are several reasons for this. Technology is, I think, a front runner. And, we feel that we are the most connected generation, the constant connectivity, which leads to, unfortunately, even though there is connectivity, we are also the most isolated and disconnected generation that humankind has ever seen. And unfortunately, this loneliness, which I know the previous Surgeon General had really, highlighted, the loneliness alone is equal to smoking to 20 cigarettes a day. That is the impact, even physically, of prolonged loneliness. And with social media encroaching into all aspects of our life, and I would say even mind, it has led to such feelings of inadequacy, low self-esteem, and I see so many young patients in their late teens, early 20s, suffering from having just no sense of self-esteem and feeling that they are worthless and they amount to nothing. And I think that social media has a big role to play in that. Our recent pandemic, its shift in the work-life balance, blurring boundaries between work and family, leaving no time for self-reflection, introspection, play, self-care, I think has contributed greatly as well. Next. We are back in another cycle of elections, and the political polarization that still persists, dividing people into the us and them, coupled with so much existential angst around climate change and environmental changes, the fires, the earthquakes, and doors blowing out of planes. It's no mystery that these everywhere you look, you feel unsafe. Unfortunately, the media does not highlight all the good that still happens in the world. It's just sort of showcasing all that is wrong and difficult and scary about our world. And on young developing brains, this can have a pretty significant impact. So, and people are young people are bought into the idea that the road to happiness is paved by getting that next new shiny gadget or that next new shiny thing. But we all know that satisfaction of desires is usually unsatisfying. And that has an evolutionary reason for it, because it's life sustaining for us to not be completely satisfied so that we can keep going back and look for food. If I had one meal that I walked a mile to get and then I was completely satisfied, I would not seek food again, and that would not be compatible with survival. So unfortunately, people and young children and young adults feel that material success will bring them happiness, but that seldom is the case. Next. Now, disparities in mental health care really saddens me, because there is, so much difficulty in people accessing good mental health care. And coupled with that is this idea of people just being reduced to a symptom complex, not just, being fully functional, amazing human beings who also happen to have depression or anxiety. So our current attitude sometimes lacks that holistic model, and it sort of reduces the patient to just a label, which is really sad. And even though awareness is increasing, the stigma surrounding mental illness is sadly not decreasing. And the stigma, it arises from a variety of different places. There is lack of understanding, there is misinformation, there is ignorance, there is fear about talking about mental illness. And, within stigma, there is people who will not talk about it because there is self-stigma. They're afraid to be seen as different. They are afraid to be treated different. And so it has many, many underpinnings. And I feel that it does do a great disservice to someone suffering from mental illness, because it discredits their suffering altogether. It reduces them from being, whole people to stereotypes. And it definitely gets in the way of them getting the care that they so badly need. So here's a quote that says, "The only thing more exhausting than being depressed is pretending that you are not." Next. Now, how do I identify whether I'm depressed or anxious? And this is a question that often, comes up where people say, what is that line between having a bad day and just not, feeling my usual self? And where does it sort of trickle over into a condition that requires specialist care and treatment? So clinical depression is a life-threatening medical illness. It is more intense and hard to manage. It definitely impacts functioning, which is one of the criteria we look at. Your coping mechanism is overwhelmed, and the symptoms persist for a period of more than 2 weeks. Now, people will often, there's sort of misinformation that depression just includes feeling sad. So the change in mood is just one of many criteria and many symptoms that the patient can experience. And even within the mood, it is a change from how you normally are. You could be sad, but in men, we usually see that the change in mood is one to irritability, to anger, to isolation. So we look for a change from how you normally are. So including the change in mood, we look at loss of interest in things that you enjoyed on a regular basis, be it, sports, athletics, socializing, your own hobbies, feelings of guilt, feelings of low energy, tiredness, a change in your sleep pattern. You're sleeping too much or you're sleeping too little. Same thing with appetite. You're eating too much, you're eating too little. So weight gain or weight loss, difficulty concentrating, becoming indecisive, needing constant reassurance, becoming very sensitive to rejection, and finally, feelings of worthlessness and feeling the world is better off with you not in it. So if you have 5 of these symptoms for a period of 2 weeks, you qualify as being depressed. Next. Similarly, with symptoms of anxiety, anxiety is a survival tool. It is something we all experience when we are, preparing for an interview, when I'm giving a talk such as this. It is a feeling of unease or worry or nervousness, and it usually includes an event that has an uncertain outcome or lives in the future. So when I advise people who are depressed or anxious, I will often tell them that people who are depressed tend to live in the past. Their mind, their worry is all about regret, guilt, and things that have already happened. And people who are anxious tend to be sort of my, travelers into the future. They worry about things that have not yet happened. And so, the road to depression is paved with regret and guilt. And that to anxiety is about worry about the future. So with, both of these times that actually don't exist, neither does the past nor the future, the antidote to both is really mindfully bringing yourself back to the current moment, which is generally worry-free. In this moment, you feel comfortable, you are in charge of what's happening, you're not anxious. And so to keep bringing yourself back to the current moment is sort of the cornerstone tenet of mindfulness. We'll talk about that. Now, so abnormal anxiety is when it's out of proportion. The response is out of proportion to the threat. Sometimes it wakes people up from sleep. It is more prolonged. And as we always look for how is it impacting your functioning, your work, your ability to get through your day. So the symptoms tend to be much more dramatic and they tend to be much more physiologic. So, oftentimes I'll receive patients in my practice who've had a several $1,000 workup with different specialties, including cardiology and GI, before everything turns out to be normal. And they come to me, and what they've had all along is just severe anxiety because it can mimic having a heart attack or having IBS. With the increased heart rate, increased blood pressure, the breathing discomfort, GI discomfort, shaking, tremors. So it's a very uncomfortable physiologic state. Next. more and more we are now thinking that anxiety and depression actually exist on a spectrum. They are two ends of a similar disease spectrum because they do tend to have a lot of symptoms in common. And I see so much overlap. It's, really unusual to find a very depressed patient for a long time who doesn't also have anxiety, and the other way around as well. So as we talked, the anxiety is a high energy state, whereas depression is a more low energy state. What they have in common, however, and what makes it hard to tease out is the common symptoms of excessive worrying, the ruminative, constantly thinking the same thought or not being able to step out of this looping pattern of thinking, the irritability, the insomnia, the decrease in focus and concentration, the impact that it has on your own sense of confidence, the isolating behavior because you feel so bad, the feelings of dread that something bad is about to happen, which leaves you feeling pretty out of control. So these are some of the overlapping symptoms that both of these conditions share. Next. Now, when do we seek help? And this is again an important, question and discussion because we can sometimes experience symptoms of depression and anxiety ourselves. And more importantly, when we see a friend, a colleague, a family member. So when do we seek help? I always say that if it is somebody that you know well, and you notice a change in their behavior, a change in their sort of reaction to things, a change in their sort of personality, remember that it's always good to check in with the person, acknowledge that you notice something is not feeling right and are they doing okay, and struggling with one or two symptoms, and if there is a trigger, a specific trigger that has prompted that sort of change, you can talk to them about it, and you can sort of keep an eye and see if those symptoms begin to get better over a week or two. However, if you feel that the symptoms are persisting and the person is really not functioning well, or their grooming and hygiene is falling off, they're missing school, they're missing work, it's a sign to seek help. And, we really push for recognition because early intervention definitely helps and makes a big difference in decreasing the amount of time that is lost by not going to school, not going to work, and the fallout from that as well. And I always say, just go talk to a mental health specialist. And at best, you learn something about yourself or about the condition, and you'll get a clean chit, clean bill of health, and all will be well. So discussing, talking with someone is something I always advocate. Next. This is another important slide. What do I do when I know someone is struggling? And, in this slide, what I have is basically talking about one major theme, which is listening with empathy and without judgment. So we all tend to be problem solvers. We like to look at life as a problem to which we bring a solution. And if someone does, bring up the courage to come and talk with us, I think that we honor them with our complete attention and our complete attention to their suffering without layering it with what I think they should be doing about it. So this is something I hear a lot, that I don't want to talk to my parents or I don't want to talk to my spouse because they're always telling me what to do. So validating their emotions, letting them know that you're there, you're listening, not interrupting them as they talk, not trying to fix it, not trying to solve the problem, and certainly trying to be conscious of not sounding patronizing or condescending. Remember, we talked that people who are depressed and anxious are very sensitive to rejection. They're very sensitive to how they're going to be perceived because they're already feeling stigmatized. So a little bit of mindfulness in when we are present with these people goes a long way. Reassuring them, checking in with them, and of course, seeking them, encouraging them to always seek professional help are some things that we can do. Next. What are some coping strategies, not just for anxiety and depression, but really for good mental health? I am an advocate for practicing good mental hygiene, which is important for really maintaining our mental wellness. And this has to be practiced regularly, not just when we are distressed, because preventative care is definitely better than emergency care. And in them, as I had touched on briefly prior, mindfulness and some meditative practice goes a long way. People sort of don't quite know what it means to meditate because there's a variety of ways of meditating, and there's so much literature out there. My recommendation usually is, if you can just for 2 minutes in the day, in the middle of your busy day, just stop what you're doing, close your eyes, just fold your hands, sit at the table where you are, and in those 2 minutes, you can just repeat slowly either a quote, a saying, a scriptural passage, something that's about 2 to 4 lines long, and you just slowly repeat that in your mind without your lips moving for 2 minutes. It really helps reset everything. So I just say start with 2 minutes, put an alarm, but do it every day. Consistency, over doing it every now and then really, really helps. And mindfulness is again all about bringing yourself to the current moment, identifying that your mind tends to, scatter and go here and there and travel into the future and revisit the past. So gently, non-judgmentally, non-critically, bringing it back to the current moment is very helpful. Maintaining a healthy lifestyle, we talk about this so much, about good exercise, good sleep hygiene, reducing your caffeine and alcohol intake. All of these practice regularly really do go a long way, and they can be sensitive indicators that you're not doing well if you see that they are fluctuating. Increasing our social contact and social connections, again, to combat the loneliness and all of its downstream effects is very important. Exploring creative outlets, journaling, art. I find humor and laughter as really being good medicine. Watching a stand-up comic show or watching, a rom-com or a funny slapstick comedy, sometimes it really helps. And, one thing that I will often tell my patients is you can fool the brain into thinking you're happier than you are feeling. And if you smile, the muscles that stretch when you smile actually sends a signal to the brain that releases chemicals that make us feel good. So even if you want to fake smile your way through some stressful event, I'm all for it. Spending time in nature. Nature is the best stress absorber we have. So just a walk in nature, even in your lunch hour, goes a long way. Practicing gratitude. I can give a whole separate talk on just practicing gratitude. It has direct changes it can make in our neural wiring and anatomic changes in the brain. They've done studies on this, and something as simple as waking up every morning and saying out loud 3 things that you're grateful for every single day, within about 4 to 6 weeks, there is a measurable change in your overall mental health. So simple thing for all of you here today to practice starting today. Next. Setting healthy boundaries. This is something which all of us, no matter our age, we all struggle with, learning how to say no. And one thing that helps me, and I try to help my patients learn this, is when we set healthy boundaries, it is not to leave people out. It's to keep ourselves safe. And so remembering that you are the most important person in your life and taking care of yourself well is really the best lesson that you can teach your children, your spouse, your family, your friends. So setting healthy boundaries and setting those limits is a good thing to do. Self-compassion, again, treating yourself with kindness. If you reflect for just a minute and you think about how you treat other people who may be suffering, and the kind words that you can spontaneously come out with to comfort them. And when you are suffering, the language, the dialogue, the words are completely different. We tend to be so critical, so judgmental about ourselves. And if you notice that, if you're aware, it's an opportunity for change. So learning to manage your stress is never a one and done. It's a lifetime of learning. It's a journey. And so it's about practicing different strategies and really owning the ones that speak to you. So being patient, being persistent, and being kind is the way to do it. Next. Final quote: better to light a candle than to curse the darkness. And, as I end, I always like to end by reminding people that the most expensive real estate in the world is the 6 inches right here. And to my young patients, I always say no rent-free squatters. Be careful of who lives here because it does determine how everything else functions. So with that, I come to an end to my presentation, and I want to thank everybody for their attention, and of course the board for their commitment to the well-being of our community. Thank you.
Thank you, Dr. Sehgal. Board members, do you have any comments?
Well done. Really exciting. That laid out so clearly and so well. Thank you very much.
Thank you.
Thank you, Doctor. Thank you.
Thank you. Very
Thank you.
practical.
Okay, we're going to now move into the reports and start with the medical staff report. Dr. Saylor.
Hi, everyone.
Hi.
That was a great presentation and a hard act to follow. So I'll start off with the medical staff census. We have a total of 627 medical staff, and of those, 343 are active staff. The remainder being split among administrative, the advanced practice providers, ambulatory, consulting, courtesy, 3 leave of absence, and several who are provisional and being credentialed currently, including provisional active, provisional advanced practice providers, provisional consulting, and courtesy. Regarding medical staff activities, yesterday we had the quarterly general medical staff meeting. That went really well from what I have been told. It was a very full agenda. We had a lot of great reports that included a report by Dr. Chet Morrison and Elwood Conway regarding the trauma program, what's been done so far, and the timeline coming up. Dr. Why am I blanking out on his name? The president of the ACCMA presented new. I'm just like, oh, sorry, I just drove home through very wet weather. I apologize. So we had a presentation regarding the new laws that affect California and in the medical community starting January 1st, and that was very helpful. Not much else has happened otherwise because of the holiday season that just ended. The aquablation program, I'll give you an update about that, is going well. More cases are coming up next week. We are doing some marketing. We have a couple of articles coming up in the Tri-City Voice, including testimonial about one of the patients that we did recently who's been very happy with his surgery. We also have a talk coming up that I'm going to give. I think it's going to be like a Facebook Live type of presentation next month that I'm working on. And I think that's it for me.
Thank you. Any questions? Thank you, Doctor. Thank you.
Thank you.
We're going to move now to the Service League report. Sheila, are you there?
Thank you, Mr. Wallace. I'm here. I'm feeling a little depressed after that wonderful presentation. I don't know how I'm going to do this one, but I will try.
Smile.
Well, good evening to all of you. Again, a warm welcome and wish you all a very happy 2024 on behalf of all the volunteers. In December, 156 volunteers contributed 1,397 hours in line with our ongoing commitment. The slight decrease in hours is attributed to the holiday month. In April of last year, I highlighted our volunteers in the Mended Hearts program who conduct patient rounds in our telemetry department. I just wanted to update you this month that the Mended Hearts program has seen tremendous growth since then. In 2023, our volunteers made 70% more visits with patients and 170% more visits with family members compared to 2022. This is in part because our volunteers made more follow-up visits with heart patients, especially those with congestive heart failure, and there was an increase in patient visitation at the hospital. This month, I want to highlight our lobby volunteers. Lobby volunteers, many of whom are students, embody values of courtesy and friendliness. They engage in responsibilities such as delivering flowers and discharging patients, contributing to the smooth functioning of our hospital. Recently, they have been charged with rounding up transport chairs which have gone missing or are misplaced and need to be returned. These volunteers have enhanced the overall patient experience, leaving a positive impact on patients and visitors. As they actively participate in real-world tasks like patient discharges, these students become better equipped to handle challenges in their professional future professions. This symbiotic relationship works well. The hospital gains dedicated support, while the volunteers, in turn, acquire valuable skills, experience personal growth, and find a sense of fulfillment through their meaningful contributions to the healthcare community. Shifting focus, the Service League is thrilled to announce our relocation to the former community library located just off of the lobby of Washington West. On behalf of all the volunteers, I'd like to thank Kimberly and the board for finding us such a wonderful home for the Service League. It's real prime real estate and we love it. So thank you so much. Stay tuned for a special invitation as we look forward to welcoming you for a visit. The volunteers eagerly look forward to the upcoming annual Service League business meeting and luncheon on February 13th. The annual meeting will provide an opportunity to reflect on the achievements of the past year, discuss upcoming initiatives, and recognize the valuable contributions of our dedicated volunteers. Invitations for the luncheons will be sent out shortly, and I hope to see all of you there to celebrate our success. That is the end of my presentation. I feel better already. Please let me know if you have any questions.
Me too.
Were you anxious to?
Thank you.
Thank you.
Just a comment, Sheila, after thinking of Dr. Seema's talk, words are inadequate to express our gratitude to the Service League.
Yes.
So I hope that helps you feel better.
Thank you. Absolutely. My depression is
It helps me, sure.
No,
I
I'm going to
love
sleep well
this
tonight.
group. They are such quick learners. I love this.
I'm going to have a good night's sleep. Thank you, everyone.
Thank you. Thank you. Okay, we're going to move on to the quality report.
Right. It is my pleasure to reintroduce Dr. Diane Martin. As we know, she has recently retired from from clinical practice at Washington Township Medical Foundation, but she is still very involved in many of our important programs, including the infectious disease program as a consultant. Many of you know she's been associated with the medical staff and the healthcare system since 1984. She has served in many leadership roles at Washington, including chair of the Department of Medicine and chair of the Clinical Evaluation Committee, which includes pharmacy and therapeutics and infection prevention. As I mentioned, she has retired from the Medical Foundation in 2023, but has continued her role as the Washington Infectious Disease Program Consultant. She is currently the co-chair with Lena Wong for the Antimicrobial Stewardship Committee and co-chair with Gulnaz Hanif for the Infection Prevention Committee. Dr. Martin also served as one of our key leaders during the peak of COVID response planning, a role she continues today. Dr. Martin attended medical school in Charleston, South Carolina, after which she completed her internship and residency at the University of Kentucky School of Medicine. She received a fellowship in infectious diseases at the UC Davis School of Medicine. Welcome once again, Dr. Martin.
Thank you very much. It's certainly a great honor and a very hard act to follow from Dr. Sagal. So I want to highlight a little bit of our infection prevention program, kind of tell you where we've been, where we're going, and where we hope to continue on certain areas and goals. So next slide. So in terms of the background, we are based on the Centers for Disease Control, CDC, which noted there are almost 2 million infections in the United States that are acquired from hospitals per year. And these are considered health-associated infections, and they can lead to complications, prolonged hospital stays, increased healthcare costs, and in severe cases, higher mortality. We've seen that strict adherence to infection prevention and control programs is essential to prevent the spread of infections in the hospital and reduce the mortality. We do surveillance, education, increased awareness, and consistently try to apply evidence-based infection control guidelines, which are crucial parts of our infection prevention program. I'm very pleased to tell you that for many years, Washington Hospital has had an outstanding infection prevention program. It is a hospital-wide discipline, and it's very effective in working on prevention, identifying and controlling the spread of infection. Next slide. So our Infection Prevention Committee background, it was established in 2006 in response to the Institute of Healthcare Improvement Request for 5 Million Lives campaign. Hospital-acquired infections were first reported in 2009 per the National Health Care Safety Network, we call NHSN, which is part of CDC. Our focus is 24/7, 365 on infection prevention. We do surveillance of the hospital environment. We use software to identify patterns in infections, and we do real-time hospital-acquired infection reporting. I work with an outstanding and highly competent team. Me, but also Infection Prevention Program Manager Gulnaz Hanif, who's an RN, MS, CSN, and CIC, which is the infection control qualifications. Quality Chief Officer is Mary Boland, who is also CIC. She was one of our original infection control coordinators and is now the Chief Quality Officer. We also have infection preventionist, Erin Spink, who works full-time, and Laura Tang, who is a per diem, usually weekend or vacation relief. We also have an enormous team, and I won't go through all of them, but they're listed here. So almost everybody in the hospital is participating on our program and contributing to it. Next slide. So program components include quality and patient safety, which is Antimicrobial Stewardship Committee, which I'll get to in a few minutes, employee health and safety, transmission-based precautions updates. We also do risk assessment for construction, which I'll mention in a few minutes, outbreak management, and COVID response planning. We involve both patients and family in terms of education, isolation precautions, hand hygiene, masking, and then for their family visitors, guidelines for visitation. We do active surveillance, and we do what's called a root cause analysis, which is an in-depth evaluation, hopefully to assess what has happened and how to prevent it for the future. The two topics right now we're working on are surgical site infections and hospital-acquired infections. In the next slides, we'll go through some of that. Staff is always involved. We have multidisciplinary rounds, we have multidisciplinary committees. All of them are participating, contributing, and giving us feedback, which is very important. We do annual education for our employees. We do orientation and training, and they also participate in the root cause analysis. From their perspective, sometimes they see things in a different light that can contribute to our improving the way that we deal with infections and that optimally the way we prevent infections. We do evidence-based policies. So these are guidelines that have come through CDC and other infection control programs. And it relates to cleaning and disinfection, sterilization of devices and equipment, focus on hand hygiene. We look at multi-drug resistant organisms management. So these are organisms who over time have become resistant to antibiotics, which are mainstream in terms of controlling and containing diseases. We also do oversight of food and nutrition services, laundry, and infection prevention practices. Next slide. So these are our data reporting to the NSHN, which is part of CDC. We also report to Centers for Medicare and Medicaid Services, obviously California Public Health Department and Alameda Public Health Department. Next slide. So these are some regulatory updates for 2024, one that's been promoted by the Joint Commission, and in terms of improving hand hygiene guidelines based on recommendations from the Centers for Disease Control and the World Health Organization. They encouraged us to set goals for improving hand hygiene and hand cleaning, which, spoiler alert, we have already exceeded our goal for 2023, which was going from 65% to 92% for our staff. So our goal next year going to be higher, which we hope to maintain and not get too depressed about. The Centers for Disease Control also provides guidelines for 2024, including mandatory COVID reporting on both local, federal, and state level, which we are definitely doing. Next slide. So what we look at is our risk assessment. So we look at a number of different areas and try to figure out what would be most important, what seems to be most on the urge of crisis or needs to be urgently looked at. So we look at data that comes from our infection control program, that comes from the laboratory, that comes from reporting. We look at what we consider high risk areas. What's going to have the most damaging impact on our hospital, and how are we going to assess that and figure out a program to reduce that. So we're constantly in a state of analyzing things, and what's the probability that this will be a more serious impact than others that are less impact. So the areas we have identified for 2024 are influenza, which is an ongoing problem, hand hygiene and personal protective equipment compliance, because this is very important in containing infections, which are not only safety issues for us, our staff, but also for our patients. We look at device-associated infections, and the major two devices we look at are the catheters used for the bladder and catheters that are used, deep line catheters used for measuring blood volume and blood pressures, and giving high dose volume fluids and antibiotics. So it's not the small IVs that are like what we call a butterfly in the wrist or the back of the hand. These are ones that are more central placed just below the collarbone. We're also looking at contamination in instruments and how to properly clean our endoscopes. We're looking at surgical site infections. So those are ones that patients have had infections after a surgical procedure. We're working to improve, prevent, and automate our infection prevention to try to make it state of the art. We also work in continuation with antimicrobial stewardship. One of the areas we're looking at is Enterobacteriaceae, which is a bacteria which unfortunately has become quite resistant to our very commonly used antibiotic, which is carbapenem. So we call this CRE, which is carbapenem-resistant Enterobacteriaceae. And what we want to do is prevent that. So many times we're focusing on how would we use antibiotics appropriately, which is part of antimicrobial stewardship. Next slide. So these are areas of surveillance for our infections, and this is also part of the program mandated by the Centers for Medicare and Medicaid Services, as well as California Public Health Department. And Washington Hospital conducts active surveillance of all infections. The annual risk assessment, as I previously mentioned, is also performed annually to evaluate our risk and see are the areas that we need to look at most specifically. And the ones we've looked at for this year are the COVID, influenza and respiratory syncytial virus, sometimes called RSV, the central line associated infections, ventilator associated infections. When patients have respiratory compromise and need to be on a ventilator, many times there are infections associated with the tubing that goes into the lungs. We're looking at those infections. We look at infections related to bladder catheters, urinary tract associated infections. Vancomycin is another one of the resistant bacteria, so it's enterococci, which is resistant to vancomycin, so we call them VRE. MRSA is methicillin resistant Staph aureus. So methicillin is one that's commonly prescribed for Staph aureus. So we're looking at that particular strain of Staph that's resistant to the methicillin. C. diff, which we sometimes abbreviate CDI, is another infection that's commonly acquired through the hospital by antibiotics. Because we normally have bacteria in our system, and when you take an antibiotic to get rid of a bladder infection, a pneumonia, or a skin infection, the antibiotic doesn't know the difference between the good bacteria, which is in your intestinal system, and the bad bacteria, which is causing the problem, and tends to wipe out everything. So the C. diff is one that's generally resistant, and what's left over and then causes another problem for the patients. We look at surgical site infections. Mostly, we look at colectomies, total abdominal hysterectomy, among several others. And again, we look at carbapenem-resistant organisms, which we call CRE for Enterobacteriaceae, CRAB, which is aminoglycoside related, and then also PA, which is Pseudomonas related. So these are strains of bacteria that are resistant to the carbapenem, which is one that we usually reserve for treating severe infections. Next slide. So what are the key practices that we want to highlight for 2024? So CDI is the C. diff infection. We have started an algorithm for that, which helps identify patients that might be at risk, and also prevention bundles that we can institute. And we have ongoing education, both staff and providers. We look at CAUTI, which is catheter-associated urinary tract infections. Many times we have nursing providers that are our champions, and one, Kathy Weinberg, helped us introduce a nurse Foley removal protocol. So the nurse helps the physician identify what patient would be best served by taking out the Foley catheter, which can trigger infections. So this is done both through the nurses as well as the nursing assistants. And those policies are updated on a regular basis. And adherence to this bundle has been monitored electronically and is also providing some improvement as we're going forward. So we want to adhere to that even more strictly than we already are. So another process improvement, not to get depressed. The CLABSI, which is the central line associated bloodstream infections, what we instituted was CHG, which is a chlorhexidine wipe. So it's a particular wipe that we use for cleaning patients as well as the catheters. And this has provided an improvement in terms of our catheter-related bloodstream infections. ClearGuard is a small cap that fits onto the dialysis catheters, which also, again, prevents infections related to those catheters. So adherence to the bundles are monitored electronically and also by our infection preventionists on a regular basis. We've also instituted COVID response measures. We want to make sure as many people in our community as well as our hospital staff get immunized. Patients who get vaccinated do much better in the long term. It's not 100%. I'll agree with that. There are complications, but in general, we think that the vaccines do provide improved care for patients and reduced infection numbers. And these resources are evaluated on a regular basis. We've also implemented enforcement of transmission based on personal protective equipment policies. So specifically for the resistant bacteria, the providers, whether the nurses, laboratory, pharmacy, lab, or physicians, we use these to protect ourselves, protect our families, and protect our patients. And we use this on a regular basis, including universal masking for these patients and eye protection, especially for ventilator patients. Some of the new strategies for 2024 are to try to reduce our surgical site infections, and our IP team observes surgeries for that to try to help improve. We continue to reduce hospital-acquired infections, such as the catheter-related bloodstream infections, the catheter-related bladder infections, and the ventilator-associated infections. We're continuing to work with our COVID response efforts. We're continuing to monitor hand hygiene. As I told you, we're really working on improving that because we did such a tremendous improvement, and it was across the board. I mean, the nursing staff, the physicians, our lab staff, all of them contribute to this. And they implement a unit-based model for data collection, which we're doing on a regular basis, and we're targeting areas that need to have increased support for that education. We continue to monitor water management, and I'll get to that in another slide. And we've implemented action items to work with real-time outcomes. We have ongoing standardization of infection prevention program, and the EPIC background that we use as our computer system helps us track this data on a very realistic and real-time basis, and it helps us in reporting to local health departments of our infectious disease and make sure that our frontline staff have up-to-date dashboard meaningful information to track trends based on Foley catheters and also on central line bundles. Next slide. So ICRA is infection control assessment of construction projects. So we do this in conjunction with infection control and try to evaluate the risks that are associated with construction projects. And these are things that are ongoing, whether it's renovation of an area that's not been kept up, so that we need to keep the standards up in terms of cleaning, maintenance, but it's all across the hospital. And we want to prevent transmission of infections to our vulnerable patients, to our healthcare workers, and our hospital visitors. So patient safety is assessed for all new construction projects and renovation projects prior to initiation to make sure that we're watching to make sure that their infection potential is reduced. Recommendations are made by the infection preventionist on safety measures. So in terms of looking at construction projects, we look at low risk, which might be ceiling tile replacement, medium risk, which would be updating audio-visual cables, medium to high risk would be sanding of walls so you can see the dust and stuff that might be generated. High risk would be the renovation of the pharmacy and sterile processing, which has already occurred this year. Next slide. So this is talking about the water management that I mentioned earlier. So the National Health and Safety Network included water management with its annual patient safety survey starting in 2018. At Washington Hospital, our water management includes temperature monitoring and bacteria testing. So we do that on a regular basis to make sure that there's no contamination of our water. So primarily we look at Legionella, but we also look at other opportunistic pathogens, which might be Giardia or cholera, which we've not had because they're doing such a good job. We also collaborate with a water quality vendor, which helps us track facility-wide what's going on in our system. So the water testing is conducted to make sure that the water is safe. Our findings are reported monthly. We also purchased a chlorine machine, which was installed, but has not yet been needed to be used, but is on the ready if we get what we call elevated heterotrophic plate counts. So this is a system for measuring bacteria or any viruses in the system. So it doesn't tell us exactly which ones are there, but it's telling us that there is a problem occurring, which we, again, have not had. But this is on the radar system to sort of alert anytime we might see something coming up in the future so that we can act on it right away. So water management education is provided to the engineering staff at the time of orientation and every 3 years thereafter. Next slide. This will talk about environmental care. So infection prevention does daily rounding and monitors compliance with environmental care, as well as with our environmental staff. And we do in-services huddles on particular issues that they're concerned about and one-on-one basis in case something comes up. We do disinfectant on a very regular basis to eliminate risk of infections. This is done daily, and especially with terminal cleaning of isolation rooms. So isolation rooms are cleaned with bleach to make sure that we get all of the possible infections. And specifically, terminal cleaning means at the end of the patient's stay. If the patient goes from one unit to another unit, that's a terminal cleaning, or when the patient's then discharged, that's also considered terminal cleaning. We do another risk assessment called ATPase testing. So ATP is an enzyme that's in bacterial cells. And when we're cleaning, we have a monitor that looks to see if the proteinaceous material is left behind after cleaning. This is a light source that does this, and it can determine any potential presence of potential pathogens. And again, it doesn't tell us specifically which one, but it's like the radar. It tells you that there's danger on the horizon and you need to drill down and figure out what's going on, what can we do, how can we correct it, how can we prevent it. So it detects trouble spots that may need to be re-cleaned or areas that need to be improved. Next slide. So again, I'm talking a little bit about our Animal COVID Stewardship Program. This was started in 2010 and monitors and evaluates antibiotics. So antibiotics have a two-edged sword, and they're very effective at curing and taking care of infections. But on the other hand, it also, over time, antibiotics develop resistance. So they're no longer effective, and we need to go to a higher and higher level of an antibiotics. So our pharmacists are mainstream on this and help us to evaluate antibiotics and where we can streamline. And again, it's not if some is more, it's better. We need to use the antibiotic appropriately for the right reason, for the right dose, for the right antibiotic. We have dedicated pharmacists, one that I work with, Lena Huang, who helps us look through all of our antibiotics, evaluate usage, looks and reviews over multiple cases to make sure that we're using the right drug for the right diagnosis for the right patient. We also target high-risk antibiotics, so we look at them very closely to make sure that they're used for the right purpose and that not just because it's the newest kid on the block. So we have usage guidelines. We educate our stakeholders. Stakeholders are basically our frontline users, which would be our pharmacists, our physicians, our nurses, but also we want to make commitment to our patients to make sure that we are doing the best for them that we can with these wonderful tools that we have to make sure that they're used appropriately. We also do screening for C. diff because we want to make sure that we're not missing something there. Because sometimes people are colonized, so they may have it. It's not an active infection, but when you are given an antibiotic, it then becomes an active infection. So we have treatment algorithms that were designed by the nurses and have been approved by a number of groups in the hospital that we use in collaboration with infection prevention. We also have tremendous physician engagement. So we work with groups of almost all the infection disease physicians who provide comment to us in groups, recommendations for changes, and updates on our programs that are needed. We also reach out to physicians that are frontline physicians, like our hospitalists and our intensivists, to give us feedback when they think that we need to make improvements or could make changes or look at things differently. Next slide. So 2024, we're looking at what we call our triple endemic. So an endemic is a disease occurring in a particular area or region. So we're looking at our area. A pandemic, which is a disease throughout the world. So COVID is both a pandemic throughout the world, but also endemic in California. So endemic, we're looking at COVID, influenza, RSV, all of that surging throughout California. We're maintaining our preventative protection equipment, which is our gowns, our masks, our gloves, and anything that we need to prevent infection. We're updating our masking policy to require currently all healthcare workers to wear a mask in patient care settings. We're asking visitors and staff to self-attest if they've had cold or fever or feeling sick. We're encouraging, please stay home. Don't come in sick. We are also following Alameda County Public Healthcare vaccine recommendations. The steps that we've done for vaccinations is to strongly encourage flu vaccine and to get it yearly and to get updated COVID vaccines. We're encouraging people to wear a mask in crowded areas, especially if you're at risk for COVID infection, flu, or RSV. And again, if you're sick coming to visit somebody or you're coming to work, please stay home. If you must go out, you must pick up your prescription, wear a mask. Wash your hands or use the hand sanitizer on a regular basis. Try to keep your immune system healthy. You can do that obviously by working to reduce anxiety and depression, but also a healthy lifestyle. Exercise, eat right, keep the weight down, get proper sleep. Stay home also if you're sick. Call your doctor if you think that you're experiencing symptoms of COVID, RSV, or flu. Many physicians are offering tele or video visits, so you don't necessarily have to come in for those. Next slide. So this talks a little bit about the COVID cases in Alameda County, and this is actually for the last year. You can see at the very beginning of the year, we were at fairly high incidence. It's gradually tapered down. We had a little bump up lately and has gone back down again. The bottom line is for new and confirmed diagnoses, our 7-day average across Alameda County. So again, very high in the beginning of the year. We had another spike at the late summer, and then it's gone down a little bit and then sort of back up a little bit, probably because of the holiday season and people gathering and getting together. Next slide. This talks about COVID mortality in Alameda County, and it summarizes it 2024, but if you look to the far right on that top bar, we're actually going all the way through our COVID experience. And you can see the very high surges that we had in 2020 and 2021 and how much better things have come. I think because of awareness, I think because patients are taking this seriously, and also because of the vaccine, and probably because of the treatment that we now have. We have oral Paxlovid and IV remdesivir. Looking at deaths by age group, obviously much higher in our more immunocompromised patients. Ethnicity seems to be kind of across the board. Early on in the illness, we did see way more in our Pacific Islander and Hispanic group. For some reason now it seems to be a little more in the Caucasian group. Next slide. So this is looking at influenza, RSV, and other respiratory viruses. Lately, we've seen a slight uptick in influenza, but again, not compared to where it was several years ago. We also see increased outpatient, which we call influenza-like illnesses, which are probably rhinovirus, metapneumovirus, also RSV in that group. We've seen a little uptick in hospital admissions lately. We've also had an uptick in deaths lately, but a little bit less in terms of RSV lately. Hopefully that's because people are taking advantage of the RSV vaccines, which is indicated for people over 60, but also for pregnant women, because if women get it when they're in their last trimester, it protects. The antibodies cross over the placenta to the baby and provide protection for the baby for the first 6 to 8 months. So if you look at influenza levels across California, our little area right now is considered in the moderate area. So this is northern Bay Area, central and upper southern area, lower southern area also has moderate. Basically, key information is the influenza is increasing as we're going through. We tend to have a peak probably in late January to February. If you've not had your flu vaccine, never too late. Respiratory syncytial virus also is fairly high in California. There are several products, as I mentioned, for respiratory syncytial virus protection. Next slide. So two of the bacteria that I wanted to highlight that we are trying to control that are seen in our hospital, but also it affects our staff and our patients and families as well. One is Clostridium difficile, which is abbreviated C. diff. It's a very contagious bacterial infection, which can cause severe gastrointestinal disease and usually associated with prolonged antibiotics. The C. diff rates have increased tremendously in the last decade. Hand hygiene and management of antibiotics are the most important measures for trying to prevent this spread. So at Washington Hospital, we established a campaign against C. diff started in 2016. Our infectious disease team looks at root cause analysis. So again, looking to see where we can make preventions, what can we do to prevent and sustain prevention. We're also looking at cleaning matrices, like I talked about, the ATBS testing, which looks for stray bacteria, also our water management, we're looking at that, and stressing hand hygiene. As I mentioned, our hand hygiene has gone up so much, and that's just on the part of our staff. Yes, we nag, but they are taking it to heart and making it a reality. The nursing have also revised our C. diff bundle, how we look at patients, what we do, how we treat them. Environmental services also has specialized teams for cleaning rooms that are associated not only with C. diff, but resistant bacteria like the CRA and the CRAB. We also had education for our teams. We're also doing ongoing surveillance, and we put up isolation signs that are very characteristic to show you what you need to do in terms of going in. Do you need a regular mask? Do you need an N95 mask? Do you need gown and gloves? Do you need just straight hand washing? So all of these are key to the particular disease that's affecting the patient. The pharmacy is outstanding in terms of helping us match the bug, which is the bacteria or the virus, to the drug, which we want to use and use judiciously. And we also have a suspected C. diff task group, mostly driven by the nurses, that helped us design a testing decision flow sheet. So when the nurse is looking at a patient and concerned, is the C. diff or not, it gives you steps to go through, working with both the lab and the team to try to figure out what to do. And not to brag, but I will, our C. diff infections was below, for 2023, below the benchmark set by NSHN. So I can tell you, we have a great hospital and a great staff. Next slide. The other thing we're looking at is tuberculosis. So this is a very age-old illness. It's less common now, but it's still very serious, and especially for our hospitalized patients, because it's not always obvious. So tuberculosis is preventable. It's communicable by respiratory, coughing, sneezing. It's causing bacteria that attacks the lung or parts of the body, including the brain, the spinal cord, and kidneys. At Washington Hospital, 100% of our employees are required to have annual TB screening. So we make sure that our patients, our staff are protected one from another, and by default, their families. We collaborate with Alameda County to monitor and survey incidents, and the county is notified by our infection preventionists if we have a case. We have had some. Usually they're patients who are coming in with this, and they're rapidly identified. We screen all patients that are suspected or confirmed. The nurses automatically start the patient on airborne isolation if the patient is a suspect. We also do continuous negative pressure, which we did for COVID, but we also do for TB in the isolation rooms. Our physicians work with the lab and the nurses to confirm the diagnosis and also initiate treatment for these patients. We coordinate to ensure that the care is appropriate, that they get medication, and that they're followed up. So these are reported specifically to the Alameda County, who will then provide nurses who make certain that patients have support both in their families support system and their own personal support system in terms of medication, isolation, nutrition, and whatever they might need. We do a lot of discharge education on this, both with patients and family, and making sure that the medication management is appropriate for them. Next slide. So now I've told you all about what we're have been doing, this is what we're going to be doing. So we want to maintain what we've obtained, compliance with health maintenance and associated infection reporting, both in line with Centers for Disease Control as well as Centers for Medicare and Medicaid Services. We're doing ongoing comprehensive multidisciplinary infection prevention rounds. Some of this is done one-on-one with nursing teams, and some is done collaborative with multidisciplinary teams that we meet on a regular basis. The data is reported and discussed quarterly at clinical evaluation meetings, nursing oversight meetings, and multidisciplinary infection prevention meeting. We're trying to sustain the improvements that we've done for the catheter-related urinary tract infections and control of multi-resistant organisms, which include the C. diff and the MRSA. And on the horizon, we have not seen much, but it's coming, is a very resistant Candida aureus. So far, it's been very, very limited, almost none so far in Alameda County, but we are preparing ourselves in terms of screening of patients when they're coming in through our ED, when they're being admitted, to make sure that we potentially screen these patients that might be at high risk. So we're definitely putting all of our resources into working on prevention for further outbreaks, working on emergencies, as well as surge management. We are always alert for new issues in terms of infections and coordinate with our staff. We continue to keep all of us, staff, physicians, patients, visitors, safe and healthy. And with that, I'll say thank you, which is the next slide. And especially to Mary Boren, Golnaz Hanev, Erin Spink, Laura Tang, and also all of the staff that's involved. And again, Wong, who's worked with me and provided tremendous support, and also cannot thank Kimberly Hart and her staff for all of their support. We could not do this without them. So thank you, thank you, thank you. You cured my depression.
Thank you, Dr. Martin. Board members have any comments, questions? Very informative. I don't understand why you don't have a Southern accent.
She worked hard at it.
But we really appreciate your report. Thank you.
Okay. And if people are thinking of things later on they want to bring up, I'm always available for questions or comments. And, you know, we appreciate so much the feedback. You may not be thinking of it now, but you may think of it tomorrow in the middle of the shower saying, why didn't you think about? So just call anytime you have comments, you know, positive, negative, we take all into consideration because we want to hear it. We want to know how we can make this the best program for the best hospital in Alameda County.
Thank you.
We're going to move on to the finance report. I got this little note.
All right. Yes, so we're going to start with Tom is going to present the November financials.
Okay. November 23 saw a lighter volumes and a little bit of a softer payer mix, so kind of a continuing story there. Inpatient average daily census was 155.2, which was below the budget of 167.8 by about 7.5%. And year-to-date, inpatient average daily census is off 6%. Combined average daily census was unfavorable to budget by 10 for November and 6 on a year-to-date, fiscal year-to-date basis. Our discharges were unfavorable to budget by 101 for November and about 8% on a year-to-date basis. Patient days were unfavorable to budget by 378 for November, and two main contributors there were OB, Peds, Special Care Nursery were unfavorable to budget by 152, and the Adult Med Surg were off budget by 143 days, respectively. Outpatient observation equivalent days were higher than budget by 78. That's not a good thing. And so for November, and then higher by 507 days on a year-to-date, fiscal year-to-date basis. The average length of stay was below budget by 19 basis points on a month monthly basis and 2 basis points higher than budget on a fiscal year to date. Our case mix index was slightly exceeded the budget, coming in at 1.481 compared to a budget of 1.466. Deliveries for the month were 116, which were off budget by 30. And on a fiscal year-to-date basis, we are off 6% or 42 deliveries for the year. Total surgical cases in November were 457, so slightly below budget by 19. However, on a year-to-date basis, we are over budget by 2 on the surgical. Cath lab cases for November at 150 were below budget by 20% or 38 cases, and we trail on a year-to-date basis by 126. Non-emergency outpatient visits were 8724. This was over the budget or above the budget by 439 and are above the budget by 233 on a year-to-date basis. So we continue to see the outpatient growth. Emergency room visits were 4959, above budget by 6. And we trail a bit on a year-to-date basis by 2.6%. A little bit of detail on the surgical and cath lab. In surgical, we had an unfavorable variance in essentially all categories with the exception of other surgical cases, which were favorable by 14. So we were off by a total of 9. But if you look at the numbers, we were single digit on all of the shortfalls. And on a year-to-date basis, favorable again by 2. In the cath lab, overall cases were below budget by 38. This was primarily driven by the peripheral vascular and cardiac, representing 35 of the 38 cases. Key operating indicators on a productivity basis. The blended productive FTEs were favorable by 91.6 for the month of November and 21.5 on a fiscal year to date, while November's blended non-productive FTEs were unfavorable by 44.7, bringing our net number to a favorable 46.9 for the month of November. Total FTEs per adjusted occupied bed of 5.98 was 27 basis points better than the budget at 6.25, and we are 19 basis points better than our fiscal year-to-date budgeted number of 6.31. Summary of total deductions. Gross revenue at $190.6 million for November was below budget by $10.3 million or 5.1%. Our payer mix, the government-sponsored patient revenue made up 72.9 or 110 basis points higher than we had budgeted at 71.8. HMO was 2.5 of gross revenue, which was favorable to budget of 2.3. So it exceeded our budget by 20 basis points. And then PPO came in at, or commercial came in at 22.3 of gross revenue, which was unfavorable to the budget of 24.5 by 220 basis points. Contractual allowance in terms of dollars was favorable to budget by $4.9 million, even though we had a softer payer mix. So we had less contractual money removed from our claims. Provision for bad debt and charity were unfavorable to budget by $5,000, which brings our total deductions to $147.6, again, slightly better than budget at $4.9 million or 3.2%. The total deduction as a percent of revenue for the month of November was 77.44, over the budget of 75.93. Summary of operations for the month of November.
I'm going to start with the net operating income loss line. Net operating loss for the month of November was $2.25 million, which was unfavorable to budget of 1.8 for a total of $4 million shortfall. Operating expenses of $46.4 million for the month of November were unfavorable. Given the 5.1% shortfall in revenue, we would have expected expenses to come down in a like way, and they did not. They were down about 1%. So it's matching our flexing to the volume that we're actually having on our supplies, costs, salary and wages, purchase services. Non-operating income of $3.1 million. This was driven mostly due to the unrealized gain on the investment of the operating reserve portfolio of just over $2 million. And then total net income for the month was a positive $900,000 on a budget of $1.74 million. And on a year-to-date basis, we are off on our net income budget of $8.4 million. So that was the GASB. And then the FASB, government entities typically use the modified accrual basis as it only recognizes revenue when it's available to spend. FASB applies to public and private companies and uses full accrual accounting, which measures the performance and the position of a company on economic events. So there is little regard to time or date of cash in a FASB report. So you'll notice that in the net operating income line, the fifth line down, our net operating loss is 2.927 as opposed to the 2.25. So slightly higher on that. The gain on the non-op, instead of 3.1 million, it's 1.4, making our net income loss a $1.5 million on a budget of a positive 1.5 for a $3 million variance. So on a FASB perspective, at the net income level, we are negative 10.4 versus the 8.5 on a GASB. And then on the EBITDA report, again, on the fifth line down, the EBITDA for the month of November was $912,000 on a budget of $4.8 million. So off about 3.9. Year to date, we have EBITDA of $5.5 million on a budget of 17.6. So we're off $12 million on our EBITDA. And then our net operating margin is negative 5.1 for the month and negative 4.7 fiscal year to date. And net income margin is 2% on a budget of 3.5 for November, while the fiscal year to date net income is negative 3.1 on a budget of 0.5% positive. And with that, Mr. Chair, I'll stop my report. Thank you.
All right, I'm going to give the preliminary numbers for December. December was a busy month for us. Yes, in terms of looking at the gross revenue, you can see patient gross revenue of $215.7 million for December was favorable to budget by $1.9 million or 0.9% and higher than December 2022 by $8.7 million or 4.2%. Now looking at it broken down between inpatient and outpatient compared to budget. On the left-hand side is the inpatient gross revenue of $129.4 million was unfavorable to budget by $8.4 million or 6.1%, but $971,000 higher than December of 2022. On outpatient gross revenue of $86.3 million was favorable to budget by $10.4 million or 13.7%, and 9.8% higher than December of 2022. Then looking at, you could just, once you hit all of them, you can put them up, yeah. These are some of the key census statistics. You can see that the average length of stay came in at 5.71. It was higher than what we have been seeing, and unfavorable to the budget of 5.2 by 9.8%. Really, in December, what we saw, there were 19 discharges with lengths of stay greater than 30 days. And so they range from 31 to 74. And if we excluded those, we would see an average length of stay of 5.13. So I know we did have some challenges with longer lengths of stay and moving and transitioning patients to that next level of care. Still in-house at the end of the month, we did have 8 patients with lengths of stay over 30 days, going from 33 to 95. Our outpatient equivalent days of 304 were unfavorable to budget by 5.9%. As you can see, inpatient daily census of 175.8 was unfavorable to budget, just slightly, I should say, unfavorable to budget of 176.4 by 0.6 or 0.3%. And then the combined average daily census of 185.6 was, again, slightly unfavorable to budget of 185.7 or 0.1%. So pretty close on that. Looking at our discharges, though, we had 948 that was unfavorable to budget of 1,052 by 9.9%. In December 2023, discharges were 39 or 4% less than December of 2022. We saw really a number of medical discharges of 740 were less than the budget of 748, was one of those, along with some of the surgical discharges being under budget. Looking at our patient day trends, patient days of 5,449 were unfavorable to the budget of 5,468 by 19 days or 0.3%. We did see ICU days at 607, which were favorable to budget by 12%. IMC days were below budget by 8.5%. Our OB and peds and special care nursery were busy. They were favorable to budget by 13.9%. Those were some of the main drivers in terms of patient days. We did have a good surgical month. We had total surgeries in December came in at 490, which were just 1 or 0.2% favorable to the budget of 489. And they were 9.9% above December of 2022. Inpatient surgeries at 217 were unfavorable to budget by 12, and outpatient surgeries at 273 were favorable to budget by 13 or 5%. And they were 13% more than December of 2022. Moving on to the breakdown, you can see in terms of the breakdown of the surgical activity, orthopedic surgery, this is all orthopedic surgery cases, came in above budget by 13. Neurosurgery cases down by 1. We did have strong cardiac surgery month. They came in over budget by 3. Vascular endoscopy and other surgery, though, were below budget by 4, 4, and 6, respectively. Looking at our cath lab, this is still really one of our major areas that have been challenged for us in terms of the volume. Cath lab cases for December at 146 were 30.5% unfavorable to the budget of 210. Our inpatient cases at 83 were 30.3% unfavorable to budget, and outpatient cases, again, also were 30.8% unfavorable to budget. You can see the breakdown really focused in all areas, cardiac, IR, and vascular cases. So continue to look at ways that we can increase the volume in the cath lab. Moving on to deliveries, we continue to see our delivery volume going up and down. Deliveries for December were 136, were favorable to budget by 7 or 5.4%, and they were 12 more than in December of 2022. Our C-section rate at 42 or 30.9% of total deliveries was 6.9% higher than the budget of 24% of total deliveries. Year to date, our total deliveries are 757, which is unfavorable to budget by 4.4%. So we're still working to get to budget on that. Moving on to our non-ER outpatient trend visits. This comes in at 8,052. That was unfavorable to budget by 262 or 3.2%. This is really mainly driven by lab visits that were unfavorable to budget. We did have fewer visits, and a lot of that had to do with the holidays, but it was offset by our imaging services that was above budget by 12.4%, and diabetes education also was up by 27.9%. So those were the major drivers in that. Looking at our emergency room visits, they came in at 5,254. They were unfavorable to budget by 143 or 2.6%, and they were less, as you can see, by about 4.8% than the prior year. But we have continuously seen higher, overall high emergency room visits. Moving on to our recap in terms of the gross revenue. Again, as mentioned, we did see total gross revenue above budget by $1.9 million. As you can see, in terms of the surgical services, they were favorable to budget by $2.8 million or 7.4%. Again, our challenge is the cath lab services, and you can see that is below budget in terms of gross revenue by $3.6 million or 29.4%, which is aligned with the 30.5% in terms of off by volume. We did see room and board that increased over budget at 1.4%. Birthing center was up over budget 410 at 12.3%. Emergency room revenue was slightly below the budget at 0.8%, or 108,000 or 0.8%. And lastly, ancillary revenue was up above budget by $1.8 million, and that's really due to the higher outpatient revenue. Looking at our preliminary payer mix, we did see less government-sponsored payers than what was budgeted. It came in at 71.7% of total gross revenue, which was favorable to the budget of 73.1%, and lower than the prior year's percentage of 73.8%. Our HMO was 1.6% of gross revenue, which was unfavorable to budget unfavorable to the budget of 2.2%. We saw this was due to 8 patients that shifted their financial class from HMO to Medicare in December. Though our PPO was 24.5% of gross revenue, which is favorable to the budget of 23.3%, and was also higher than the prior year's percentage of 21.8%. We are also having some challenges with private pay. You can see that came in at 2.2% of gross revenue, which was unfavorable to the budget of 1.4%, and also higher than the prior year's percentage of 1.4%. We have a total of about $1.4 million in charges from out-of-the-country patients. In December, there were 8 accounts with charges exceeding $100,000, and one of these had charges totaling over $500,000 too.
What's the collectability of that?
It takes a long time. It's very low in terms of that, because it's very difficult, because it's having to try to track them down overseas. So, yeah. Preliminary productivity indicators, productive FTEs were unfavorable to budget by 18.9 or 1.3% at 1,518.1. As you know, we had a busy month, so our productive FTEs were over budget. Our non-productive FTEs were favorable to budget, and basically just given all the holidays, we still weren't able to get staff out. And it was favorable to budget by 48 or 21.7%. Total FTEs of 1,691.1 were favorable to budget by 29.1 or 1.7%. Our productive FTEs for adjusted occupied bed of 5.18 was favorable to the budget of 5.48. And the total FTEs per adjusted occupied bed of 5.77 was favorable to the budget of 6.29. So, as I said, we were very busy. Moving on to outpatient statistics. On the left, you can see Washington Township Medical Foundation. The clinic visits were unfavorable to budget in December by 310 or 1.8%. They're pretty close to budget, and higher than the December of 2022 visits. Our primary care, including pediatrics, was favorable to budget by 126 visits. We saw unfavorable to budget in specialty care, 5.2%, and that was mainly driven by open positions that we have currently in orthopedics and psychiatry and vascular. Then moving on and looking at the Radiation Oncology Center, in December, the radiation oncology visits were 21.9% below budget at 336. We've been really looking at this and just want to clarify, these are visits, and so looking at actual patient numbers, we're pretty much aligned with the budget in terms of patients. Over the last few years, we have, with our new equipment and protocols, we've been able to provide more precision dosing to our patients. So we haven't not had them been able to come in as, they don't need to come in as for as many visits, basically. And so that's what the treatment visits are. So that what we're seeing, and that's really the two drivers, is that, the number of fractions that patients have to have in terms of the dosing is less than in previous years. And so I think it's something that we're going to actually have one of our radiation oncologists come and just give a little bit of an educational session on it and talk about some of the changes in this and really look at some of the metrics that we're using too.
Should use a different.
Right, in terms of it. So we've been looking at it in terms of it, and the machine, I will say the machine was down for one day in December, but really what we're seeing is more of how the care is being delivered.
I think the patients are happier to have fewer treatments.
It is. They're very much the same. That's why I didn't say it as well as you just did. The same, same dose, fewer treatments. So I just wanted to talk a little bit about that. And then moving on to the DevCo outpatient statistics, they came in at 1,857. It was favorable to the budget by 14.5%. And really, this is driven a great deal by the rehab center. It was unfavorable to budget by 20.6%. We had the holidays, and we also have one full-time physical therapist on a leave of absence, and two other physical therapists were taking time off. So that, as you know, is an entity that we've had some challenges in terms of staff turnover. Our surgery center visits at the Washington Outpatient Surgery Center were favorable to budget by 16, and our Peninsula Surgery Center visits were favorable to budget by 20 or 40%. And lastly, Ohlone College Student Health Center visits were unfavorable to budget by 32, given some of the holidays. So moving on to the key financial statistics, our days cash in hand did decrease by 2 days. A great deal of this was really due to the holidays in the month in terms of having less days of collections, and so we saw that, and that also impacted our days in accounts receivable. Just given the holidays and the ability to do the collections, and also December, we saw the growth in gross revenue because of how busy it was. There were higher census with higher charges. So that also resulted in higher days in accounts receivable. It is coming down already in January at this point. So we had 159,000 in charity care adjustments. And then lastly, in terms of the 6 months of looking at unhoused activity, total reimbursement cost for the period of July to December is $3.5 million. For the 6-month period from July to December, there were 1,999 patient encounters representing 589 unique unhoused patients. Of the 589 unique unhoused patients, 186 had multiple encounters. And just to remind the board that the total unreimbursed cost of care includes food, clothing, pharmaceuticals, DME, transportation, and other labor and avoidable inpatient days.
Are there any state or county programs to help offset these
There aren't any more in terms of that. It's one of the things, I don't know there hasn't been on the state, and it's one of those things to talk about on the county level, in terms of looking at that. We can look further into that too.
State's really in a tight spot now.
Yeah. So, but we can look at, any county funds, yeah. All right, those are the December.
Thank you. Any questions? All right, then, let's move on to
Okay, I'm going to start with Employee of the Month for January of 2024. That's Lena Nguyen in Case Management. And just want to make sure everybody aware of case managers play a critical role in the care we provide to our patients and in the efficiency of our organization. Certain patients need a little extra review before it is determined that they can be safely discharged, and case managers play an important role in this. So in talking a little bit about Lena, in 2021, Lena Nguyen was working on her master's in case management at Samuel Merritt University when she accepted a preceptorship at Washington Hospital. Lena was impressed with many aspects of Washington Hospital, including collaboration between case managers and the nursing staff and physicians. Upon graduation, she accepted a full-time position, and Lena has grown with her role. She is a quick and enthusiastic learner and trains new hires, and she is a key resource for her coworkers. She's always looking for small ways to improve the department processes and the quality of patient care. Lena is well known throughout the hospital as someone who can work on any unit and who will volunteer to take some of the most challenging cases. Her manager, Kelsey Walden, describes Lena as having a special talent for working with families who have difficulties understanding how to navigate the healthcare system. Kelsey notes that Lena has received many positive compliments from patients and their families. With regards to our patient-first ethic, Lena proudly states that she strives to always make her work patient-focused. She tries to speak directly with a patient to get to know them as a person first and then as a patient. This hopefully makes patients feel like their concerns have been heard and their needs will be addressed. Lena appreciates the collaborative environment where she is comfortable acting as a patient advocate when needed. The collaborative environment is what Lena most likes about working at Washington Hospital. Yeah.
She's very good.
She is very good, and she is recently started her doctorate in nursing program at Samuel Merritt University and plans to be completed in 2025. So congratulations, Lena. And then I'll just move on to our promotion events for our community outreach. We had just a few in December, and as they're coming up, I will begin to show them. On December 14th, let's see, Washington hosted a health education booth at the Thornton Middle School Health Fair, and we had 1,900 students that were in the 6th to 8th graders that attended. On December 18th, Dr. Seema Sehgal, as we know, she's been busy talking about anxiety and how to beat the blues, and she did this on Facebook Live and YouTube, and she had 73 live views, but 335 non-live views. December 21st, Kidiyama Elementary School Fair, we hosted a health education booth, and Dr. Joyce Liu, our vascular surgeon, participated, and we have 300 3rd to 5th graders who attended. And lastly, also I just want to mention collected coats and blankets throughout the month of December and provided 8 bins, and this is our employee association for the healthcare system, provided 8 bins of items collected for the Viola Blythe Community Services. So great job to all of our employees. And here are a few pictures of a couple of the events. On to the next. And then you can see we have some upcoming health promotion and community outreach events. We have one of our physicians in family practice medicine physicians on January 11th talking about cervical health. Why is it important on Facebook Live and YouTube? We have one of our emergency physicians, Dr. Whalen. She's going to talk about naloxone, a lifesaver in the opioid crisis, and that's also going to be on Facebook Live and YouTube. Dr. Joyce Liu, Our vascular surgeon is going to be talking about leg pain and wound care on January 22nd at Pauline Weaver Senior Living Community. And then on the 31st, Dr. Zayed Imnan, our gastroenterologist, dysphagia and reflux disease, and he'll be talking at Acacia Creek Living Community. And then moving on to February, we also have 3 events on the first part of the month. Tammy Tyson and Christine Mickelson are going to be talking about breast cancer prevention, early detection, and treatment at Carlton Senior Living Community. On the 8th, Dr. Ramin Begi, a cardiothoracic surgeon, will be talking about the TAVR program, our minimally invasive procedure for heart valve replacement. And then Dr. Mark Saleh, as he mentioned, our urologist, is going to be talking about aquablation on Facebook Live and YouTube. As you also can see that our Hospital Healthcare Charitable Foundation will be holding on Thursday, January 29th at 5 p.m. in Anderson Auditorium a free charitable giving and estate planning seminar. So that's open to anybody who would like to attend. And also want to mention the 37th Annual Golf and Bocce Tournament will be held on Thursday, May 2nd at the Castlewood Club in Pleasanton. And then also we will be having our Foundation's annual meeting on January 30th in the Anderson Auditorium. And that is the presentation.
Thank you. Any questions? Okay. We are going to adjourn to a closed session. However, before doing so, I want to let the public know that they have a right to know what the reportable action, if any, was taken by the board during the closed session. Normally, the board would make that announcement following the closed session. As we do not know how long the closed session will last, we do not want members of the public waiting indefinitely for the board's report. Therefore, we ask you to contact the district clerk tomorrow. She will be happy to respond to any inquiries about reportable board actions. Our minutes will continue to reflect any reportable actions taken. Thank you. The board will now adjourn to a closed session.